good evening, sir, and I'm glad you are here today and guide us on this really interesting and very basic topic, which we all need to understand as a physician. So, interpretation of CBC and newer parameters. Uh, Dr. Mahadev Desai, he's a consultant physician practicing at Ahmedabad. He has over 35 years of teaching experience, and sir, he's an amazing teacher and has joined us today. So, I'll stop this. Uh, Before I hand it over to you, sir, I'll just run few polls, and that will give you basic idea of what we are going to learn today. And let's see how what all things you know right now. And once is done with all the parameters, some previous parameters, older parameters, and some new. That's things will be really beneficial for you to understand as a physician. So let's run through that poll, and then we'll start. So should I start with the poll, sir?
Yeah, please go ahead. Good evening, everyone.
So here goes your first. So there are some CBC values, HB, RBC, RDW, and MCV. So looking at these values, what do you think is the most likely type of anemia? So can you see the final results? Most of them have answered iron deficiency anemia.
We'll not discuss right now. I will really say all the four choices.
Great.
And later on, during the course of the discussion, we can again project and then decide.
Definitely.
Is that all right?
Yeah, sure. I'm running the second poll, which has different values and some same options actually. Let's see how you all respond. Again, there is a CBC report. Again, four values, four important values, and what is the most likely type of anemia. Great. So here goes the last poll in this. Vote quickly. We have a timer also at the bottom. Great. So we have the results with us, and I'll hand it over to Sir now. Let him explain, and we'll go through that poll again, and then we'll discuss the answers.
We will discuss during the we don't want to discuss right now because we don't want to jump to the conclusions of the different types of anemia straight away without having a background. So maybe we'll discuss during the course of the discussion. But right now, fine.
Over to you, sir.
Yeah. Good evening and welcome everyone. And I'm very happy to see such a large number of gathering at an odd hours. And indeed, it's a great pleasure at Medflix for all of us to have discussion of this kind of topics. And as I can see, when I scroll through the number of participants and their different specialities, I can say that there is going to be something for everyone, something to know and something to get bored also, right? If that doesn't belong to your specialty, but hang on and at least remember that these newer parameters that we are going to discuss is going to be the order of the day, and virtually every patient will come out with this kind of sophisticated reports, and at least we need to know how to interpret these reports. Even if we don't know the nitty gritty of how that comes, at least we should know what they indicate and the basics of this. So that's the very first idea. Before that, disclaimer: I am neither a hematologist nor a pathologist. I am a practicing consultant physician. So my talk will be more clinical based and not much of the statistics or much of the figures and data. I'm going to talk about ABC of CBC and not A to Z of CBC. So don't expect everything that we are going to discuss about every aspect of complete blood count. That's not possible in a limited time, and it's not required for most of the people who are attending this. So make sure that what we are going to discuss is more of a curtain raiser or a very primer of the interpretation of complete blood counts. And most of the slides and the material that we have taken are from the websites or the friends who have taken their topics earlier, and I'm grateful to all of them, and nothing belongs to me. So what I'm going to discuss is the in two-part talk. First is the conventional parameters which we routinely order and which are available at any corner of India. But the newer parameters are specifically available with the laboratories which are sophisticated and which have got the automated. Now, when we say CBC, when we write CBC, CBC mean different to different people. So make sure that if you want these informations, you better write everything rather than just write CBC, because there is a habit of writing complete blood count and people will come out only the reports of hemoglobin, WBC count and the platelets and nothing more. That's not what we want when we say CBC. When we say CBC, we want the RBC indices also. So it's better to mention what we mean by CBC rather than what the pathologists interpret as our order of CBC. So that when we want CBC, we would like to have at least hemoglobin, the red blood cell counts, the RBC indices. Routinely we do hematocrit, mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, and newly added RDW or red cell distribution width. Then WBC, we want the total count as well as the differential count and the platelet counts. This is what we want for CBC. We also want ESR in all our patients, and we also want the good peripheral smear. That's very, very important. So this is what we mean by conventional parameters, and we'll be discussing each and every aspect of this CBC. Then the newer parameters, that is part 2 of my talk. Here we are going to discuss about the neutrophil lymphocyte ratio. I'm sure most of the people know because of the COVID pandemic that this has come into highlight. But the real newer parameters are one which are given by the automated hematology analyzers, and they are really giving a well. There is an immature granulocytes, nucleated RBCs, red cell fragments, the immature reticulocyte fractions, immature platelet fraction, or mean platelet volume. So same thing that we look for in CBC, the RBCs, WBCs, and platelets are further added informations over and above the information that we get in the CBC. These informations will be added to and without any extra cost. So that's why they are very, very important. I have purposefully posed these slides in the initial so that you get time to these different terminologies. Some of you might have heard for the first time, but this will have to remember and interpret in the time to come. So first and foremost, the hemoglobin. Obviously, this is something that basic we want to have for each and every patient when we ask for CBC. We know hemoglobin and all these values which are given as normal may differ from textbook or from the pathology or from the race and the community. So make sure what I have given is generally acceptable, the values, and there may be little variations which is not to be discussed further. Males usually 13.5 to 17 grams hemoglobin and females 12 to 15 grams. And the WHO definition of anemia is less than 12 gram. Anybody who has hemoglobin of less than 12 gram is labeled as anemia as far as the WHO definition is concerned. When do we get high hemoglobin? See, if somebody's hemoglobin comes to 16 or 17, definitely it's high. But we need to know where, and every parameter, whether it is hemoglobin or TCDC or anything, we have to correlate with the patient's history, and it's always to be interpreted in clinical context. That's why I said, being a clinician, I know the parameters can be abnormal, right, because of the pre-analytical errors. That means there may be faulty collections, or there may be the diluents or the anticoagulants are not added correctly. So never ever interpret one single reading without having a look at the patient's or the patient's history. And when in doubt, better to repeat rather than act upon an abnormal reading. That's very, very important. So polycythemia, when the hemoglobin concentration is more than 17 gram percentage, it's polycythemia. It could be because of the genetic defect, and that we'll talk later. But very importantly, whenever somebody's hemoglobin is very high in the context of having a fever, joint pain, headache, severe backache and all, and we are suspecting dengue, then it assumes very important thing. Hemoconcentration is the reason for high hemoglobin. Nobody's hemoglobin will rise from 13 to 14 to 15 in a matter of 2-3 days time without having been transfused blood. So it's very important that if the person's hemoglobin on day 1 of the fever, say suppose is 12, and the next day is 13, and the next day after that is 14, surely you are dealing with something like dehydration or dengue. In dehydration also the same things happen because of hemoconcentration. So any abnormal reading need to be serially checked, and then only we can save. And it's very, very important parameter. Anybody having a dengue and proven dengue and the hemo concentration occurs by more than 20%, there are very high chances that they will go into complications like dengue shock syndrome or dengue hemorrhagic fever, and we should be on alert, and patients should be instructed to take as much fluid as he can take. If there is a question of vomiting or not taking orally, that patient need to be hospitalized for that purpose. So that's about the high hemoglobin. Polycythemia, we need to investigate in more detail. There can be secondary polycythemia also, that because the hemoglobin may go up, right, in other conditions. The next is normal. If somebody's hemoglobin is normal, right, maybe he is in good health, but I have put a question mark. Why? If the patient has suppose emphysema or chronic bronchitis, that seemingly normal hemoglobin is not normal. What we expect in a patient with emphysema is secondary polycythemia or higher hemoglobin because of the hypoxia. So a hemoglobin of 13 in a patient with emphysema, long-standing chronic bronchitis, may not be normal. That's why we have just put the mark, and we have to see the overall patient's outcome. Then if the hemoglobin on day 1 is less, it could be because of some blood loss which is overt or occult, or there may be hemolysis. It's very important to remember the broad causes of low hemoglobin. It could be blood loss, it could be hemolysis, it could be chronic anemia, or patient might be having some coexisting chronic or congenital conditions like thalassemia, that's inherited hemoglobinopathy. So it's very important that hemoglobin is very important parameter to begin with, but always remember, if the patient has previous reports, it's worthwhile to check. If somebody's hemoglobin has been persistently 9 or 10, either he has some chronic anemia like iron deficiency anemia, or maybe he has thalassemia. We'll be further discussing later. It's important to remember that hemoglobin, by what we do by the conventional methods like Sahalis method or sign hemoglobin methods, there can be falsely high hemoglobin also. If the patient has hypertriglyceridemia, a patient has hemolysis or cold agglutinin disease or autoimmune hemolytic anemias, the hemoglobin may go up in spite of patient's actual hemoglobin being low, right? So it's remember that hemoglobin can be falsely elevated also. Next is RBC count. The red blood cell counts in males is 4 to 6 millions per cubic millimeter, and females is 3.5 to 5. RBC count, again, like hemoglobin, obviously will be increased in polycythemia or secondary polycythemia, right? Like the chronic bronchitis, emphysema we said, or maybe a congenital heart disease. And again, like hemoglobin, it can be hemoconcentration, or it can be spuriously increased when the patient has increased WBC count. It will be decreased in anemia and spurious decrease in cold agglutinins that we discussed with hemoglobin. So practically hemoglobin and RBC count go almost parallelly, except one of our questions was there in the poll also, right? When the RBC count does not decrease in proportion to the low in the hemoglobin, think of thalassemia trait or thalassemia minor. So very important, and we'll be discussing further about this also. But remember this part, whenever you see hemoglobin, also see the RBC count and try to correlate whether the fall in hemoglobin and fall in RBC count match or they deviate. WBC count is very important. Again, routinely ordered, we ask for total count as well as the differential count. The total count is normally range from 4,000 to 10,000 per cubic millimeter. And whenever there is increase in the count, we call it leukocytosis. And when there is leukocytosis, what we need to concentrate on the differential count and see whether the leukocytosis with abnormal cells like leukemic cells, then the pathology would have mentioned whether it's an acute myelocytic leukemia or acute lymphocytic leukemia or even chronic myelocytic leukemia, where the counts will be high, very high, maybe 50,000, 1 lakh, and also there will be abnormal cells on the peripheral smear examinations on in the report. But if the patient has leukocytosis without abnormal cells or maybe very few abnormal cells, then we say it's usually because of the bacterial, viral, or parasitic infections. So here we need to see the differential count. And if there is neutrophilia, that the absolute neutrophil count is more than 8,000, then it's usually pneumonia, urinary tract infections, sepsis, inflammations, vasculitis, and also whenever the neutrophil leukocyte was there in an elderly patients with having some vague joint pain, right? I would also keep in mind adult onset steel disease, AOSD. So all these rare conditions also we have to keep in mind because there is no specific diagnostic criteria for such diseases like Still's disease. We have to rely on the history and some of the parameters like this, and maybe we add serum ferritin in that case. Then if there is lymphocytosis, mind you, I have not given the complete list of neutrophilic leukocytosis. We are just giving the few representative conditions that can reach the increased neutrophil counts. Lymphocytosis, when the absolute lymphocytosis count is more than 4,000, it's usually because of the infectious mononucleosis, tuberculosis, mumps. Even in dengue, we might find lymphocytosis. What is important is we have to discuss with the pathologist for whether there is activated lymphocytes. Right? That's very, very important in conditions like dengue. Monocytosis, we don't routinely look for it, but whenever there is more than 10% of the monocytes are present and the absolute count is more than 500, then we think of conditions like malaria. But remember, conditions like after post monsoon, we have leptospirosis. Then brucella is always then the differential diagnosis of all undiagnosed fevers. Then rickettsial infections, they are not very uncommon, right? We have started seeing the scrub typhus and many rickettsial fevers, and so is leptospirosis. So we keep in mind leptospirosis, brucella, particularly when the patient's fever is not a routine one and there is monocytosis. And when there is eosinophilia, obviously we'll think of something like parasitic infections or allergic disease, or we have to check the patient's drug history. Many drugs produce the eosinophilia and they can also produce fevers. Any patient has fever and having been taking certain drugs like phenytoin, suppose, then we have to correlate with this. The leukopenia, the other side of the WBC count, when the count is low, obviously we always think of the viral fevers. There are so many viral fevers these days, dengue, chikungunya, even COVID, there can be lymphopenia or the normal count with low lymphocytes, lymphopenia rather than leukopenia. But we also keep in mind, at least in the first week, there may be the enteric fever when the counts may be normal or on the lower side, right? And again, drug-induced, many drugs and chemotherapeutic agents will produce leukopenia. Then reactive lymphocytes, I just discussed that in some conditions like infectious mononucleosis, dengue or mumps, will have activated lymphocytes, and we should discuss with the pathologist about any abnormal report. It's just they are on call away. It's better that we discuss because they may not know the clinical background, and it's very, very important, pertinent that we take the initiative to discuss with the pathologist, or when we write in the requisition form, we make a mention that this is what we suspect. Then they will better look at the slides again if there is any doubt. So it's very important, right? Next is platelet count. The normal platelet counts is anything from 1.5 to 4 lakhs, but we define thrombocytopenia when the platelets counts are less than 1 lakh per cubic millimeter. Platelet counts again are very important, and now we give a lot of importance to the platelet counts, and here lies the automated hematology analyzers. They give far more information than the conventional parameters, but nonetheless very important. We see thrombocytopenia in so many conditions, but these days we are most important in the two conditions, that is the dengue as well as chikungunya, as well as malaria. Malaria, especially the Vivax malaria, we have seen so many patients with thrombocytopenia. All thrombocytopenia or lower platelet counts do not need hospitalizations, do not need platelet transfusions. Dengue fever, especially, we give platelet transfusion only if the patient is bleeding or the platelet counts are below 20,000 or patient has pre-existing conditions or patient is elderly. Otherwise, you don't need to give the platelets. Platelet thrombocytopenia is more of a surrogate marker for dengue rather than the diagnostic feature of dengue. The diagnostic figure is the uh, test is either dengue NS1 antigen or you go for the RT-PCR for the, we have now got the RT-PCR for dengue and chikungunya also. And we see so many positive patients these days. So most viral fevers can have thrombocytopenia, but keep in mind malaria and there can be mixed infections. This season particularly, we can have mixed infections. So keep an eye open and look the peripheral smear more closely for any parasites that we might see. And immune thrombocytopenic purpura is always a differential diagnosis. Any thrombocytopenia persists. Actually, look for the patient's previous reports. If the patient's count has been something around 60,000, 70,000, 80,000 platelet counts, it could very well be the ITP. And because the patient has no bleeding tendencies and somebody has not pointed, he may go undiagnosed, but it's important to diagnose and keep a watch on the patients having a low platelet counts. Then some of the, even in India, some of the regional abnormality about the platelets. There are northern sides, northern India, especially Bengal and Assam and all, they have sometimes the low platelet counts without any problem. They are called the hereditary macrothrombocytopenia, that the platelets are large in size. And that's also to keep in mind. Whenever the patient comes, we keep in mind where he's coming from. Even if we are practicing the western side, if the patient happens to belong to the eastern India, we keep this in mind that there may have a thrombocytopenia without any clinical features and we have to interpret accordingly. Drug induced, we know that so many drugs, especially drugs like heparin, we know linezolid can cause, if a person takes it for more than continuous 2 weeks, then linezolid can also cause. Chemotherapeutic agents obviously will cause thrombocytopenia. TTP is a very serious condition and we have to keep in mind, especially when the patient is sick or patient has neurological symptoms and the peripheral smear is very peculiar for the thrombocytopenic purpura. The chronic liver disease, the other day we talked about that because the thrombopoietin is produced in the liver as well as bone marrow, can be also one of the cause for the one of the feature of chronic liver disease. Hypersplenism, alcohol can also cause thrombocytopenia. Platelet counts on the higher side. If the platelet counts are more than 4.5 lakhs, we call it thrombocytosis. And it could be because of the genetic mutations, because of the JAK2 or the other uh, genes, or that is called an essential thrombocytosis. But more often, it is because of the acute blood loss. Whenever there is an acute blood loss, the bone marrow responds in all fragments and will get the high platelets. So low hemoglobin, obvious blood loss, and low high platelets, don't worry about the platelets part. Concentrate more on the hemoglobin and the cause of blood loss. That's very important. But it's frequently seen high WBC platelet counts, and patients point more towards the, because it is highlighted by the pathology. So they will comment more about, worry about the high platelets, not to be worried about. Patients who undergo splenectomy, obviously we expect the thrombocytosis. Then we have seen many obstetricians are in this audience, and remember, for in any patients who are pregnant, persons who are pregnant and their thrombocytopenia has to be always at the back of the mind. And HELLP is no longer a benign condition and it's also considered as a variant of the preeclampsia or preeclampsia with complications is. And we already discussed about this even at the time of liver function test interpretations. Very important conditions generally occurring in the second half of the pregnancy, right? Myeloproliferative disorders can initially to begin with thrombocytosis and then there is going to be thrombocytopenia and pancytopenia. ESR, yeah, erythrocyte sedimentation rate. Yeah, Rucha, any questions?
Yeah, there is one
Yeah,
question relevant
sure.
to this.
Yeah.
Uh, if there is the thrombocytopenia but there are no clinical features, what could be the cause of it?
See, thrombocytopenia is a marker, right? And most of the time there is no bleeding, right? And you don't need to attend to that. We just to have a watchful observation for that patient, and you have to see in what clinical context that thrombocytopenia is low. It could be low because, as I said, because of the just a patient happens to belong to a particular area, and that he is born with a big platelets, is born with the big platelets, and that big platelets form a clump, and the platelet counts may be lower side, but actually the platelets are not pathological, they are active, and you don't need, in fact you will be surprised to know that I had a patient of chronic ITP, right, where we subjected her to bone marrow aspiration with a zero platelet. So patients don't bleed. Necessary patients don't bleed unless there are some other issues. So it's important that you just don't give only platelet counts as long as there is no bleeding tendency. But if the patient is on drugs like NSAIDs, or if the patient is an elderly, or we have to keep patients complain of headache, we will be worried about the intracranial bleeding. So not that we disregard it, but platelet alone is to be interpreted with the other features. I hope that's satisfied the answers. Or if there are any questions, they can ask subsequent questions.
So there is one more. So what all other investigations we should go for ITP?
See, the ITP is an immune thrombocytopenic purpura. That means we have to demonstrate that these platelets are destroyed peripherally. How can we so say that? The diagnosis of ITP comes only by showing the bone marrow aspiration and showing that the bone marrow is normally functioning or producing enough number of megakaryocytes. It is the peripheral destructions. But generally, we don't go for it. But that is how the diagnosis can come only from the bone marrow aspiration showing increased megakaryocyte. But this is where the newer parameters would help you. That I'll be discussing when we discuss the newer parameters. That we can definitely say that this is thrombocytopenia is because of the peripheral destructions.
Yeah, rest
Yeah,
of the questions we can complete. Yeah.
right. So ESR, again, erythrocyte sedimentation rate, also called SED rate by the our Western counterparts. This erythrocyte sedimentation rate is not interpreted correctly or most often, for the simple reason is the values that are given by the pathology laboratories most often are far less than the values which we encounter in the clinical practice. The reason being, these values are not that these values are abnormal, but these values represent to the young people most often, while the ESR keeps on increasing with the age also. So the good rule of thumb is that always try to reduce see the age of the patient and divide by 2. That is the maximum ESR as a normal variation for that. If the person is 50 years, then 25 would be a maximum upper limit, and that is why, because most of the patients would always complain that my ESR is very. Is there anything wrong with my blood? Basically, we know what is ESR. ESR is an erythrocyte sedimentation rate. So what we do in a specific tube, the Western green methods, the anticoagulated blood is allowed to stand, right? And we measure after 1 hour how much RBCs have settled or how much is the plasma, right? So that is what we do. It's a very sensitive marker, but not a specific marker. It just indicates that probably the person has some kind of inflammations or tissue damage. Some injury also the ESR will rise. Infections, any infection which is bacterial viral, it's going to rise. So it's a very sensitive marker, but it's very important to use it as a serial for the response to treatment or a prognosis. And it's also important in conditions like collagen disease, where we serially measure after starting a specific treatment and see whether ESR falls. ESR is affected by many parameters, like if the patient has acute phase reactants like fibrinogen, alpha antitrypsin, haptoglobin, or even CRP. CRP is a phase reactant, and CR can affect the ESR. Only thing is CRP is much robust than the ESR, but very expensive, almost 3 times the cost of ESR. And CRP rises fast and disappears fast compared to ESR. So ESR is something we have to keep in mind. And in the next slide, I'll show that ESR is important, but important mainly when we see the extremes of ESR, right? And ESR, the laboratory has to wait for 1 hour or sometimes 2 hours. I fail to understand now whether the 2 hours, except the little increase in the sensitivity or specificity of the second hour, most of the time 1 hour suffice. But the newer automated machines can now even give the ESR values in 20 minutes, which are comparable to ESR values of 1 hour. That we have started seeing. We have sent the blood, and within half an hour, patient comes with the ESR report. We are worried how come it comes, but this is the reason. ESR is very important when the values are very high. When the ESR is more than 100, it's a red flag. We have to search for the cause. It's not normal. So maybe patient has chronic infections like disseminated tuberculosis or malignancy with metastasis, or patient has any of the collagen diseases like hypersensitive vasculitis or giant cell arteritis, for which probably there is no other laboratory test. We don't go for the temporal artery biopsy often. We just see the clinical feature, headache, PO, right, maybe some visual disturbances and very high ESR, right? We every reason after ruling out the other collagen disease, we might give just a trial of prednisolone, and within a day or two, we'll know whether we are on the track. Polymyalgia rheumatica, giant cell arteritis, they are all practically same, different part of the body is involved. Clandestine macroglobulinemia or hyperphosphatemia. These are the conditions when the ESR is extremely raised. We don't need to discuss the much higher part of it. Very low ESR, right? What we mean by very low ESR is less than 5 millimeter, right? If we have diagnosed few conditions when the patients have come with joint pain and very low ESR, generally we expect very high ESR or at least normal ESR. But when we take the history and we see it's probably an acute hemolytic crisis, and ESR is low, very low in conditions like sickle cell anemia, polycythemia, patients with congestive heart failure, hypophosphatemia or hypoproteinemia. So it's worthwhile remembering and just have a look. If the patient's ESR is very low, could this be one of these conditions? Maybe it's a blind shot, but sometimes we are rewarded by just looking at some abnormal parameters like this. Now coming to the peripheral blood smear. Peripheral blood smear is very, very, very important. And we need a good pathologist friend to help us in coming out with many important diagnoses by correctly interpreting the peripheral smear. The important part starts with the collection of the blood and preparation of the good peripheral smear and good staining. It's very important, and send it to a pathologist who is well versed with the microscopic and has patience and time and passion to read the peripheral smear. It's very important because peripheral smear is, I would say, it's as important in a patient's right fever or any unknown condition, fever or say acute illnesses as is ECG for a patient with chest pain. I would give too much importance to peripheral smear, and we have so many diseases which can be diagnosed by peripheral smear or strongly suspected. Uh, so this is the peripheral smear. You can zoom out and see, right, the different parts. You can see that this particular peripheral smear, the picture is taken from the up to date, and we are grateful, very useful medical information sites, and we often use it. Here we have seen that the WBCs, one WBC is in that's a small lymphocyte, and we know that small lymphocyte has practically very little cytoplasm. It's mainly the nucleus, and all the RBCs have to be compared as far as the size of the RBCs are concerned. We talk of microcytic, macrocytic, normocytic, but how do we do without getting the RBC indices? The pathologists look at the smear and say that this is microcytic. This particular one is a normal peripheral smear because most of the RBCs are rounded and they are just the size of almost the size of the nucleus of the small lymphocyte. This RBCs you can see as also showing the hemoglobinization, except a small 1/3 part of the RBC is pale. Most of it is a condensed hemoglobin. So this is a normal peripheral smear. This slide should be in your hard disk, and then you can always compare with the subsequent slides and know. So this is what is normochromic normocytic RBC, right? So what we do, as I said, well prepared, well stained peripheral smear is very, very important. And what we see in a peripheral smear is the size of the RBCs. Any variation in the size is called anisocytosis. It can be microcytic, macrocytic, or dimorphic. Then shape of the RBCs are called poikilocytosis. It can be different shape like the spirocytes or ovalocytes. There can be different shape, abnormal shapes within the smear because of the liver or kidney diseases. And we also look for the parasites. It's mainly the malaria. Kala azar we hardly see, at least in the peripheral smear, more often seen in the bone marrow, but once in a while we might pick up with a heavy parasitemia even in the peripheral smear. So what is important is we look at the RBCs, right? And we see also here, see the normal smear is on the left corner, and as we said, the lymphocyte is our the comparator, right? And you can see that in the right corner there is one lymphocyte, I mean polymorph, which is hypersegmented, and the most of the RBCs are also much bigger than this, right? And there is also some hypochromia, so it's a macrocytic RBC. As against that, the left lower corner, you can see they are all pale. There is hardly any hemoglobin. Its central pallor is much expanded, a very thin rim of hemoglobinizations, and they are all small. So this is microcytic RBCs. The other one is the macrocytic, and the last one, the right lower corner, is, as you can see, there are many cells which are small, and there are many cells which are sickle shaped, right? So this is a sickle cell anemia. These are just the representative, and we have to discuss with the pathologist. But what is important, the role of pathologists come in situations like this when the patient is critically ill, patient is anemic, patient might be bleeding, patient might have neurological symptoms, and we want to know whether we are dealing with some kind of thrombotic microangiopathy or thrombotic thrombocytopenic purpura. Here, the peripheral smear is very important. If you find the abnormal RBCs, the abnormal shape of the RBCs, right? The abnormal shapes like the RBCs might be spiculated, having some spikes, or RBC might look like the helmet cells, as you can see. They are just look like the helmet, or they might find that the RBCs are microspirocytes. Spirocytes are the one where there is no central disappearance of the central pallor. If the hemoglobin is condensed fully, that the whole RBC is rounded and full of hemoglobinization, that is called spirocytes. These are the spirocytes which have lost their capability to deform, right? We know the RBCs are about 7 to 8 millimicron, and they traverse through a capillary which is smaller than that. How? That is because they are dumbbell shaped, and they can just pass through these small capillaries by changing their shape. They have dumbbell shape and they can pass. But spirocytes can't do that because they are rigid, and that is why they get trapped in the spleen and they produce the hemolytic anemia. And that is where we just remove the spleen and the patient is cured. So that is hereditary spirocytosis. But we are coming back to the peripheral smear or the spirocytes. These spirocytes are, I mean, the cystocytes. The cystocytes are the abnormal fragmented cells, and they are different shape. And a good pathologist can point to this. There may also be clumping of the RBCs showing the Role formations, again an evidence of hemolysis. So patients having DIC or patients disseminated intravascular coagulations or patient having thrombotic thrombocytopenic purpura, pathologists give a big help, and we can then further take up with the hematologist or through certain investigations and diagnose and treat faster. Very importantly, we also look for the RBC indices. We look for the packed cell volume, or also called hematocrit. Then we look for the mean corpuscular volume, mean corpuscular hemoglobin, mean corpus hemoglobin concentrations, and RDW or red cell distribution width. Hematocrit is routinely asked for. What is hematocrit? It's the volume of red blood cells that occupy, right? The volume occupied by the red blood cells in a given volume. So in males, the packed cell volume or hematocrit is around 45, females it's 38 to 40. And a very simple rule of 3, that is, when you want hematocrit, just multiply hemoglobin by 3. That's usually plus minus 3 is a rule of 3 for the hematocrit. And for hemoglobin, RBC multiplied by 3.3 plus minus 1.5 is this. This is very, very important, especially when the hematocrit and hemoglobin do not match, right? Patients who is dehydrated or low hydrated, hematocrit and the hemoglobin will not match. That's where it is useful. But remember, this is useful only when the RBCs are normal. With abnormal RBCs, this rule doesn't apply. So it's just for the convenience, but otherwise, what we need to see is the detailed analysis of the parameters. The mean corpuscular volume is the hematocrit upon the RBCs, which is something around 78 to 100 femtoliters. Femtoliters 10 raised to minus 15. And again, the values may differ from laboratory to laboratory. Generally, it is 78 to 100, or some levels mention 75 or 80 to upper limit of 95 or 99. So this is just a range. The anything less than 78 or 76 is called microcytic. Anything more than 100 or 95 is macrocytic, and depending on that, the anemia can be classified as microcytic, normocytic, or macrocytic. The mean corpuscular hemoglobin is the amount of hemoglobin in an individual RBC, right? So it's generally measured in picogram, that is 10 raised to minus 12, 27 to 32. Anything less than 27 is microcytic. For mean corpuscular hemoglobin concentration is measured in grams per deciliter, and it's decreased again in microcytic like the iron deficiency anemia, but it is increased not only in macrocytic but also in hereditary spherocytosis. So when the patient's MCHC is very high, right, then we have to look again for the peripheral smear and see whether we are dealing with simple macrocytic or something like spherocytosis. Next is RDW, red cell distribution width. We did talk about the red cell sizes in the peripheral smear, what we call N-isocytosis. Same thing, but it is electronically measured, and this is done in the automatic analyzers, that they give the distribution volume of the RBCs. So within the RBC populations, some may be young, some may be old, some are the normal young or the adult. So here, if the patient has some kind of anemia, then the RBC size will differ, right? But if the patient has only one condition like thalassemia, the RDW remains same. So it's very important, and we'll see the importance in the next slides, that RDW is a very important simple parameter of giving some idea about whether we are dealing with the iron deficiency anemia or the thalassemia. So this is the slide which gives the comparative values of the different commonly types of anemia. The normal values of RBC count, as we said, is anything from 4 to 6 cubic millions, and the normal MCV is around 70 to 100, and the normal RDW, red cell distribution rate, is anything from 12 to 50. If the patient has iron deficiency anemia, there is decrease in the RBC mass or the RBC count as well as the MCV. Both are reduced, but the MCV is not reduced so much, right? But the RDW is always higher. So iron deficiency anemia, low RBC, low MCV, and high RDW. As against that, the thalassemia, the RBC count is nearly normal. In most of the conditions, it's nearly normal. We are talking thalassemia trait. Thalassemia major is a different conditions, right? We are talking of thalassemia trait or thalassemia minor, where the RBC count is generally not affected unless there is a coexisting iron deficiency. So thalassemia, the RBC count, whenever the patient's hemoglobin is low but the RBC count is almost normal, keep a mind possibility of thalassemia minor and try to rule out by the screening methods, right? And here the RDW is not different because most of the cells are almost of the same size. So the red cell distribution width size is not different. While B12 and iron deficiency, because of the deficiency, the cells which are recently produced may be larger size in B12 or smaller in the iron deficiency anemia, and the older cells are all the normal size. So the RDW is different in deficiencies, and they are always on the higher side, right? And whenever it comes to the RBC indices, there is one index called Menzer index. This is a very simple mathematical formula where you just see the MCV and divide by RBC count. If the NCV divided by RBC count is less than 13, it suggests thalassemia, and when it is more than 13, it suggests iron deficiency anemia. Many of the pathological reports would indicate Menzer index. Remember, value of 13. The very pointer is that in thalassemia, you will have more smaller RBCs with a nearly normal hemoglobin, while in iron deficiency anemia, the RBCs are small, but the hemoglobin is also less. So the index is always higher than 13. Say this is one type of reports that we see routinely. Here first see the hemoglobin. What is hemoglobin? Hemoglobin is 13. The RBC count is 4.39. Almost normal, we say 4 to 6 is normal. Now look at the MCV. MCV is 92.9. So again falls in the normal range. Now look at the RDW is 13.6. So here lies a patient's report where the hemoglobin is normal, RBC count is normal, the MCV is normal and RDW. So it's a Normal report, absolutely normal report. As against that, see this report. Here the patient's hemoglobin is 9.3, definitely low. But what is the RBC count is 5, normal, almost normal. And MCV is markedly decreased, 64.7. But the RDW is high. So what do you think? This probably patient has not only thalassemia, he also has coexisting iron deficiency anemia. This much we can get right from this much report itself. We need to confirm with the other studies like we can go for the HbA2 estimation for thalassemia screening, or we can go for the serum ferritin, serum iron and all, right? But always correlate the hemoglobin, RBC count, RDW and MCV all together and you will get the picture immediately, right? The last one, here the patient's hemoglobin is 9.5. Hemoglobin is 9.5. MCV is 8 and 3.28. RBC count MCV is, so what is this? So different because loss or patient has a high memory. And the last one, hemoglobin 12 reduced
Hello.
3.59 MC. So in this particular hemogram, the MCV is 99, the hemoglobin is 12, and the counts lymphoma. Maybe this is an early part, the megaloblastic anemia. So what I was talking was that reticulocyte count is not totally ordered, but it has to be ordered. And I wouldn't give a single tablet of iron or B complex without having the reticulocyte count, because one tablet can also change the picture. And reticulocyte count, we know the reticulocytes are the precursors of the RBC. Or reticulocytes count are, there are one kind of cells with RBC. See, peripheral smear, when they are peripheral blood, they don't have the nucleus. But reticulocytes contain a large quantity of RNA and DNA, and that need to be stained with a specific stains, right? Stain or the supravital brilliant cell stains. Then we can get the reticular pattern. That's why they are called reticulocytes. Very important. Whenever the reticulocyte count is reduced in a patient with anemia, either it is a substrate deficiency or chronic, or BH, either hemorrhage, hemolysis, or hemolytic. Whenever there is increase in the reticulocyte count, it's either hemorrhage, hemolysis, or patient has been receiving hematinic, and that's why the deficient bone marrow is now getting the substrate and it's producing more RBCs and the reticulocytes, right? So very important, always go for increase for the reticulocyte counts, and always see a patient of anemia. Don't treat patients without the reticulocyte counts. That's all about the conventional parameters. And now we have got the same parameters in a newer form. The NLR is the neutrophil. This is in the center. Asking, sir, but again, let me tell you, the NLR is just the ratio of how much is the neutrophils to lymphocytes, and it's considered a very important parameter. So the NLR is nothing but the neutrophils to lymphocyte ratio, and it can increase in bacterial infections, which we see more often. But in the COVID-19 infections in this pandemic, initial part when we did not have much of the parameters, or when the facilities of RT-PCR was not there, probably we went for this. And there were initial studies which showed that whenever in initial part, when we did not have much of the details information available, we used to see that the NLR ratio of less than 3 is a good prognosis, and whenever the NSR ratio is high and the patient is in ICU, it carries a bad prognosis. But very important to remember that if the patient has received steroids, it will change the whole game, because there is anyway going to be neutrophilic leukocytosis. So NLR ratio not really very important. What is important is the next round, bear with me, that's major part is over. Now we'll have only 10 or 15 minutes for the newer laboratory parameters. All these parameters may not be available in every part of the country, and these parameters are possible only when the laboratories use the automated hematology analyzers, which the cost runs in lakhs. So only the bigger laboratories would keep it, but it's very important. They give lot of informations here. The because it's a just electronic instruments and no technical error or man-made error is likely. It gives large number of cells it count in a short period of time. Manually, it is not possible to count innumerable cells, right? We get a quicker results, we eliminate human errors, we have many more parameters which can predict the faster response of our treatment or the prognosis part that we discussed when we said dengue better parameters are coming. And the electronic all these instruments have the inbuilt software where we can have the program and we can put that if this report is abnormal, give me a flag. So there are flags generated which can indicate the abnormal results. That abnormal result can be artifact, it can be really abnormal results. You need to check it with the conventional parameters there. So it's not that the conventional parameters are out, they are never going to be out. We need to counter check with the conventional parameters always, right? So what are these newer parameters? They all the reports would come like this. These are all the histograms and the scatterograms, right? They work basically on the principles of electronic impedance and optical scatter. So the all the cells are lined, kept in the electronic analyzers, and here they just pass the light through a very small aperture. All the cells are in lined, and depending on the degree of the size of the cells, right, and the different stainings are also done. They can come out with the different types of scatterograms and wealth of information. We can get the individual lymphos. We'll come to that later. So what do we look for? We look for the newer parameters like immature granulocytes. We'll talk about it. There is a one slide for each. Immature granulocytes, nucleated RBCs, ratio of microcytic to hypochromic RBCs, the fragmented RBC, what we saw in the peripheral smear as cystocytes, then immature reticulocyte fragments, something equivalent to what we look for the reticulocytes in the peripheral smear with a specific stains. Here it comes inbuilt. Then immature platelet fraction and mean platelet volume, right? So all these, there are parameters for WBC series, the RBC series, and the platelet series. We'll take one by one, a very small part of it, don't worry. These immature granulocytes are the nothing but the fraction of the neutrophils which are earlier, premature. That means whenever there is an infection, there is a large number of WBCs are produced, and they will come, which we may not be able to see in the peripheral smear, but here we can see the immature granulocytes as a special different kinds of scatterogram. If you need to just zoom it and see the relative positions of the different cells on this kind of diagrams, right? If you want to see further, you can see here that the monocytes in the center, atypical lymphocytes on the top, immature granulocytes on the right side, and the lower downs are the eosinophils. Then also there are nucleated RBCs. So everything is there in one slide, and depending on that we can just, and that is also given in the figures. This is all given in the histograms, scatterograms, as well as in the figures. Whenever the immature granulocytes, it predicts the infections and sepsis almost on the same day or the next day, rather than we have to wait for the serial counts to go up or the blood culture and all for the sepsis. Here we have informations, and increase in the immature granulocytes on a daily basis can give you the picture that something is not well. So nucleated RBCs or the NRBC is another important parameters which we cannot see in the conventional. What is nucleated RBCs are? As I said, the RBCs, when they come to the peripheral blood, they lose their nucleus, right? So as long as they are in the bone marrow, they have nucleus, and what we used to call it normoblast is nothing. Nucleated RBCs are nothing but the normoblast, right? So these are the erythroid precursors, and they lose the nucleus and they come to the peripheral smear. They will increase much before the reticulocytes increase. So NRBC, we don't have to ask for. These newer parameters come straight away by the newer meta-analyzers. So they will rise same like the reticulocytes. As we said, no, reticulocytes increase in all age, hemolysis, hemorrhage, or hypoxia state, or persons on hematologic treatment. So same way NRBC can also give the pictures. And here it's given in one of the patients that from day 1 to day 1 month, they have seen that the nucleated RBCs have reduced gradually, and that means the patient is improving. So it gives the prognostic marker in ICU patients. If we follow up the NRBC on a regular basis, we can get the informations. I am not going to talk the details because it's not required. All that we need to understand, this is a primer, right? Just like the fragmented RBC or cystocyte that we see in the peripheral smear, that need a good pathologist and experienced pathologist to look for this, be confident about the here. They straight away it comes as a lower panel compared to the RBCs on the upper panel, the FRCR on the lower panel, and that gives the idea that something is not wrong. The normal upper limit of the fragmented RBCs or the cystocytes, which can be in any form, whether it is a helmet cells or the crenate cells or a spiculated cells, all these are cystocytes, and normally they are less than 1%. If they are high, there is a very high chance that patient is dealing with some kind of thrombotic microcytopenia hemangiopathy or TTP or DIC. The ratio of microcytic to hypochromic RBCs, we just discussed the iron deficiency and thalassemia. It's very important. If the ratio is lower side, it is iron deficiency. If the microcytosis is more than the hypochromia, it is thalassemia. And it can easily be seen at just a glance that iron deficiency, there is going to be more hypochromia and less microcytosis compared to thalassemia, which is more microcytic. The retic count we have already talked about, but we need a specific stain in the conventional parameters. Here it comes inbuilt, and they give not only the reticulocyte count, they give the hemoglobin content of the reticulocyte count. Hemoglobin content of the reticulocyte. So the first thing that affects in erythropoiesis is the precursors and the cells which are still in the bone marrow. So if you can pick up the hemoglobin content of the reticulocytes, we can almost forecast or whether what is going to happen. So or when we start the treatment, the first thing to occur is the change in the reticulocytes and the change in the hemoglobin of the reticulocyte. So this is the importance of these kind of newer parameters that they can pick up, or they make us 2 or 3 or 4 days ahead of the conventional parameters. And whenever the reticulocyte count is showing a value of less than 27 picograms, it suggests anemia. Immature reticulocyte fragments, just like the immature platelet fraction that will come. The immature reticulocyte fractions give a different picture than the reticulocytes. We can see here the immature reticulocytes are different than the normal reticulocytes, and the picture. See, immature reticulocyte fractions are very important because they are just the first part of it. They contains more RNA, and this will give the picture that the patient is suffering from B12 or iron deficiency, or patient has. If you start erythropoietin treatment, the response will come immediately in increasing the IRF. So these are the parameters which help us. And if suppose the patient is given chemotherapy for the cancers, we know whether there is an effect it's on the bone marrow. So basically all these parameters are important to understand the response of the treatment, very important. The last is the platelet parameters. The most important is immature platelet fractions. The platelets, we get a lot of importance to the platelets, especially when there is a dengue as a pandemic, and perennially we can see not pandemic, but it's a perennial present throughout the year. We have patients of dengue, and there is the patients, they know a lot of the platelet counts and all. There is too much of pressure of giving the platelets, and we are tempted, but we know platelets are a very live products. We should not give it unless it is indicated, because there are lots of complications with the platelets. Platelets don't come from one donor. It's always from multiple donors. So we are subjecting the patient to lots of multiple donors platelets, which can carry lots of infections and all, right? So platelet parameters like immature platelet fractions. The immature platelet fractions are the platelets which are released in response to the thrombocytopenia. Whenever there is thrombocytopenia, the immature platelet fraction count will rise, and that will give the idea about whether the platelet counts are destroyed peripherally, then the IPF will go up. But if there is a bone marrow failure, then imperature platelet fractions would not rise. So not only it gives the idea about the etiology of the uh, thrombocytopenia. If the patient had normal platelet count and IAPF increase, that's probably we are dealing with some myelofibrosis. So these are all the way we can judge about the uh, because of the IPF, we can know about the cause of platelet disorders. It's very important, but most important to me, the help of IPF is in the dengue patients when the thrombocytopenia is there, but the immature platelet fraction is more than 10%. If it is there, we can say that this patient is on the path of recovery, and in a matter of next 48 hours, the platelet counts will return to normal or start showing recovery. So there is no need of giving the platelet transfusions because the bone marrow is doing the job. So there is no need. So this is where these newer parameters help. And the last is the mean platelet volume, just like the IPF is also very important. And here, as I said, see some of the patients in the certain part of the India, they are born with the large platelets, right? So it's very important if the main platelet volume is high, right? With thrombocytopenia, we know that it is an ITP, right? Rather than some bone marrow pathology, but it can be high in myeloproliferative disorders also. But there probably the platelet counts would be normal. The low MPV is suggestive of aplastic anemia or a rare hereditary disorder. So the point is what we see in the conventional parameters can be preponed or can be seen ahead of the time by using the newer parameters. There is a lot of things that need to be discussed. It's not that these newer parameters are without the false positive and false sensitive reports. They are, right? We need to have the interpretation with careful interpretations, and whenever in doubt, we have to correlate with the conventional parameters also, right? It's very, very important. So I just say that the conventional parameters are widely available, very useful, and they are obviously the required in most of the patients in acute as well as chronic illnesses, and everybody is well conversant with it, whatever uh, discipline you belong to. But newer parameters are very important and they give a lot of informations, and they definitely reduces the human errors, more accuracy, and practically hardly any cost is involved. If you have to go for the other parameters separately, the patient has to incur the cost. But all investigations need to be correlated with the patient's history, physical findings, and they need to be repeated. One single value may not justify the starting the treatment. It's very, very important that we look at the CBC more carefully, and whenever required, you ask for the patient's previous reports. Somebody having a thrombocytopenia for a long time, we are dealing with ITP and not dengue, even if he has come with fever, right? So like this, you always interpret all the reports, right, keeping patients in the mind, and always have look for the previous reports also. I stop here, right, and ready for any questions that are remaining on the second part.
Yeah, sir, sure. Thank you for beautifully explaining this ABC of CBC. Really loved it and stop presenting and
It
explain
still
it
remains
again.
ABC and not A to Z. I can tell you there's so many things to be taught, but not for everyone. I am sure I have taught enough and bored also enough to many of the people. So yeah, any questions or
So yeah, there are so many questions actually, and if you, any one of you wants to ask the
yeah, somebody has asked the question of when to go for IPF, right? So that means the IPF is an immature platelet fractions. If you do the see now, most of the if the patient is in the hospital, will go for the CBC daily. Ideally, the patients are admitted in a dengue in a critical period when the platelets are required to be done daily, and we look for the IPF on daily basis, right? Because it's a automated hematolyzer that is always available with hospitalized patients, right? So we need to go for it on a daily basis. The point is when the patient's thrombocytopenia or the platelet counts are falling, or on the day the patient's fever has gone, the next 48 hours are very, very crucial, because this is the time when the patient is likely to go into the complications like the hemorrhagic complications or the dengue shock syndrome. there it is very, very important. If the platelet counts are low, but the IPF is more than 10%, we need not just give the platelets out of panic or out of desperation or because the patients are demanding or the relatives are demanding. We just convince them that wait, there is all our parameters. In dengue, we know that the dengue is always uh, right. Uh, there are some warning signs. It's never that the patient will suddenly go to patient may have abdominal pain, vomiting, or hypotension. All they will give the idea that the higher some complications are coming.
Right. So
Yeah.
in post-dengue infection,
Hmm.
can patient have chronic thrombocytopenia?
No, no, no. Dengue is just an absolutely a very time-bound illnesses, and the platelet recovery of the platelet count itself, the beginning of the convalescence period. So I don't think that the ITP dengue can get converted into ITP. Maybe that any infection can just unmask an previously existing ITP, but dengue itself would not lead to ITP.
Okay. So Dr. Yug, I guess that answers this question as well. What you have asked. Uh, then just give me a second. So how do we differentiate between which is actually the most accurate marker,
Hmm.
CBC or total count? Uh,
I did not get it.
uh,
CBC?
Dr. Himanshu, can you please elaborate your question? I'll ask that again. Uh, so I guess rest of the questions actually you have covered.
I know one of the
In
questions
answer
that
the
asked
question.
is in details of MPV. This was in relation to what I said earlier that some of the people, particularly
Yeah.
when we see a patients coming from the Assam or Bengal, they are born with the large platelets. They are called macrothrombocytopenia. If their MPV is more than 13, the normal value is 7 to 12. But if they are not bleeding, their platelet counts are low. But we don't need to really get panic and we just observe them. If they are, as long as uh, uh, their platelets are functional and we don't have to worry. But if they have bleeding tendencies, see sometimes the large platelets they do not do their functions of the plugging because they are not as efficient as the regular platelets. In that case, we need to treat like the thrombocytopenia. But otherwise, in most of the patients, it is not required to. We need to do anything. It's just in variations they are born with, and most of them don't need any treatment for that.
Okay. There is one interesting question by Dr. Kesar. So,
Hmm.
Covishield vaccine induced thrombosis and thrombocytopenia.
Hmm. Right. That is something that I think is a little definitely it's there in 1 in million, but it's a real definitely that see basically the vaccines can induce the antibody productions. So vaccine any other just like any other virus or the part proteins can produce the so it's a vaccine induced the platelet antibodies and that will produce thrombocytopenia. It's definitely when it occurs it's very very important and I think this has led to a lot of morbidity and even some deaths also. See, whenever the patient is given this, it occurs usually in the first few days and more often with the first dose. And whenever the patient has been given the vaccines and here it has produced headache or some dizziness or all this, we need to have a high alert and we should be looking for these different more detailed investigations. But it's a reality and that is why some people believe that they should be given, but there is no point in giving prophylactic antiplatelets or newer oral anticoagulants drugs because that kind of details are not available.
Okay. Sir, what is RDWSD and RDWCV, which is more accurate between
I,
these two?
I really look for it, but I am honestly not aware of the second part of it. Uh, so generally we go for the rate cell distribution with as is given in the percentage, the normal ones being 13 to 15. But I am not really very sure about this. Maybe you need to deal with the pathologists because they would be able to understand that part clearly. I do not know. Somebody has asked about can eosinopenia occur in typhoid fever? Very good questions. And yes, yes. Whenever the patient has high grade fever, we look for the differential count and we look for the eosinopenia. Patients with very high grade fever, right? And if the eosinophil count is zero, it's considered as one of the surrogate marker for enteric fever. And remember, we always go at least if the patient, typhoid is a typical illness where the patient is usually very high grade fever and no localizing findings, in the sense that there's no running nose or no urine disturbance or cough or cold or something. So very high grade fever, on third, fourth day or fifth day only we ask for the sonography. But eosinophenia is definitely one of the important surrogate marker for typhoid fever, agree. And sonography to me is a better investigation than the Vidal test. Vidal test, so many people go for Vidal test in the first week. It's never positive in the first week. The antibodies need time to develop. So it's usually come the second week, and there are a lot of false positive in Vidal. I would go for the sonography. A good sonologist can pick up the ulcers or edema or the terminal ileum where the typhoid ulcers, or maybe mesenteric lymph nodes, or maybe hepatosplenomegaly. Yeah, somebody has mentioned about the SDW and CV1. Yeah, I'm not aware of it. Honestly, I'm not aware of it. Yeah.
Can dengue present with hemorrhage with coagulation?
Uh, Generally, the dengue presents with the thrombocytopenia and bleeding tendencies only. I don't think that it's present with, unless it can lead to the DIC, and as a DIC can occur with any infections, and then we can have both in the phase of the consumption of the clotting factors. We have both, on one side there is thrombosis, on the other side there is bleeding. It's very, very tricky and difficult to treat such kind of patients. But yeah, that's the only way. If we produce DIC, yes, it can.
So we have two raised hands as well. So I'll just
Yeah, sure.
quickly
Yeah,
accept the
sure.
request. Uh,
Sure.
Hello,
You are audible now.
everybody.
Good evening. Yeah.
My query is regarding the thrombocytosis.
Hmm.
One of the causes you had mentioned, HELP syndrome.
Yeah.
As I can remember, the classical teaching is that HELP syndrome has low platelet. Just
No,
want to
no,
confirm on that.
no, thrombocytosis. I don't think there is HELP syndrome in the thrombocytosis. It's in thrombocytopenia only.
But the slide where the thrombocytosis was written, HELP syndrome was written one of the causes. Just want to clear on that.
I need to check. Yeah, I am sure it's the very acronym is the hemolysis
HELP.
with elevated
Liver enzymes
liver
and low
enzymes and
platelets.
low platelet. So if
But
it is
it
there,
has
it's probably, yeah. If it is mentioned, then it's definitely need to be corrected. I'll check it, and
thank you,
definitely
sir.
it's not
That
correct.
was my
Yeah.
query.
No,
Thank
no,
you.
no.
Thank you.
That's absolutely, it's a low platelet, always low platelets.
Okay, okay, sir. Thank you.
Good to point out, and thank you, and good that this
Thank you.
others don't go with that impression that you can get thrombocytosis also there. No, thank you.
Thank you. Thank you, sir.
in RA patient, which parameters of CBC is increased? Uh,
You mean rheumatoid arthritis?
Arthritis.
Yeah, generally, see, in rheumatoid arthritis, initially there may be monocytosis like any other collagen diseases, but important one is ESR and CRP only. So we go for ESR and CRP only as a serial measurement whenever and there will be anemia. If the patient is in acute inflammatory stage, right, then definitely there will be anemia, there will be ESR and CRP will be raised. It doesn't affect much of this unless the patient is on treatment. Then we need to go for the CBC serially. But otherwise, per se for rheumatoid arthritis, what we need is an anemia and high ESR.
Understood. So and this question has come up like 3 times about this. So patients with low platelet count for years, and there are no clinical symptoms as such. So does that person need to be evaluated? What could be the cause?
See, always, if there are low platelets, we have, as I said, the most important is either they are born with the low platelets, or there is abnormal platelets, large size platelets, or there is chronic ITP. If it's a chronic ITP, see, we may not treat if there is no bleeding, but we have to keep in mind and we have to serially follow, because once in a while we might need to give steroids. The point is, if we can make out that this thrombocytopenia is a part of ITP, we can increase it, particularly if the patients are female and they have menorrhagia or such issues, or they have to undergo surgeries. Then definitely we have to bring that platelet counts to the acceptable limits for any surgery. But otherwise, routinely they don't need any treatment. But if it is, many times the patients are given steroid just because they have thrombocytopenia, and it may be just, as I said, the macrothrombocytopenia, because the large size of the platelets, they don't need steroids. In fact, it might harm. So we need to find out the cause. We need to get the details of whether the patient is receiving specific drugs which can produce thrombocytopenia, and whether it's a beginning of some kind of myeloproliferative disease, right? So definitely all low platelet counts, low hemoglobin have to be investigated. No question about it.
So there will not be a situation where there is just low platelet count. Other parameters will also go down, right? If
There can be low platelet counts because of the, just as I said, they are born with the large platelets with lower number, right? That is possible. That is called,
that's one possibility.
yeah, that is called Harris uh, uh, some syndrome. I don't remember exactly, but that is what we find in the northern India.
And could this be associated with hyperbilirubinemia? So that's one last on this chain.
Hyperbilirubinemia. See, if the patient has chronic liver disease, right, then we know there can be thrombocytopenia and there is involvement of the liver. So definitely, or there may be the biliary cirrhosis and all. They are all the diseases where there may be thrombocytopenia. So it need to be investigated.
Right. So
And
in
bilirubemia can be, yeah, unconjugated bilirubemia. Patient has hemolytic anemia, right, and some G6PD deficiency, something. So point is that we need to investigate any abnormal report. We should not take it on the face value, right?
from CBC, how do we differentiate between bacterial and viral, as well as parasitic infection? So there are three.
Right. See, it's just we cannot say swear and say that this is this, but in complete in the CBC, if there is a bacterial infections, the WBC count will be very high, and it's mainly predominantly polymorphs, right? And if you do CRP also is very high in bacterial infections. As against that, in viral infections, the WBC count is normal, right? Initially, there may be neutrophilia, but the WBC count is never very high, right? And even if it is high, most of the time, then the second part, in second round, it will be the lymphocytosis, viral infections, and ESR or CRP is never very high in the viral infections. In parasitic infections, usually the WBC count, total count remains normal, but it's the eosinophilia that may be high. But again, it's not sacrosanct, and just by the CBC report, you cannot say this patient has to have bacteria, this patient has to have viral or parasite. Yeah.
Just last one question I'll take before we end it here. So other than COVID, in which condition NLR is significant? In which other condition?
See, we have said that NLR is just indicative of what is the neutrophil to lymphocytes. What is important is there a lymphopenia or there is a neutrophilia? See, that is what. So when we see the total count, if the total count is normal and there is a marked degree of lymphopenia, definitely it indicates the patient's immune system is attacked, and that is very critical, whether it is COVID or dengue, any other condition. So very low lymphopenia is more important. So whenever the NLR is more because of the lymphopenia rather than the absolute lymphocyte count is less, or the lymphocyte count is 3, 4, 5 rather than the normally we get 20 or 30, right? So if the lymphopenia is there, that's far more dangerous, right?
So there is one question where there are a lot of different opinions on the CBC changes in COVID patients. So just that one, if you can address.
See, I would say simply there are few issues in the COVID infections, right? Issues are, one is there can be secondary bacterial infection, one, and second part is use of steroids. They will change the picture completely. Otherwise, in COVID per se, probably what we expect is the COVID is florid or patient has a severe cytokine storm, then what we expect is a further lymphopenia, right? And but if there is a patient with secondary infection, bacterial infections, the counts, neutrophils will go up, and the total count will also go up, and your CRP will just double in the next 48 hours, like that. We also have, if there's cytokine storm, we'll have IL-6 will rise. So we need to go for all these parameters. And if the patient is on steroids, it will change the picture. It will all will come down. Steroids will produce the low, it will increase the lymphocytes, I mean, the neutrophils, but the lymphocytes are not affected, and the CRP and also falls will be low because of the steroids.
Yeah. Okay. Perfect. So I hope all of these questions that you have addressed right now satisfies you and answers all the questions. I can see many more coming up, but in the interest of time, I would request you all to put all your queries on support ID, and we will try and get back to you on that. To support@medflix.app is the email ID, and you can mail us all the queries that you have. many doctors have asked if this session will be made available, or will we get the PPT. So PPT will not be mailed you separately. You can watch the session again. You can go to replay section of the app after 48 hours, and you will see the recording of the session. You can watch the entire session again. So this is how you
Yeah,
will
just
get
a minute. Some Dr. Shreya has asked a question. If Menzer index is 14, but serum iron is normal, what does it suggest? So I would not say that Menzer index is again the only thing that we decide whether patient has iron deficiency. No? And serum iron alone is also again not important. We have to go for the overall picture. And if the Menzer index is 14, that does not mean it patient has to have iron deficiency. It can still be thalassemia, right? It can still be thalassemia. We have to go for the further test to decide, but I would go for the serum iron ferritin SIBC, right, and decide whether there is iron deficiency anemia coexisting.
Okay. So Shreya, I hope this answers beautifully your question. Yeah. So with this, I guess we can end the session here, and
Thank you.
hope to see you again really soon with some interesting sessions.